So hello friends, here I am with my next video regarding patient support system in NTEP. Short topic, so hopefully it would be a short video, but yes, very important topic at the same time. Now what does NTEP stand for? So NTEP, as most of us would know, stands for National TB Elimination Program. So National TB Elimination Program. Now, what comes to our mind first up is that why do we require patient support systems? So, friends, we have to remember that suppose someone has a fever, you have a patient, he has a fever. Suppose it's a viral infection, or it's a pneumonia, or COVID, or even in acute conditions, some conditions like typhoid may linger around for a longer time. They may go into a subacute range. So there we are talking about treatment that lasts from days to at most weeks. The minimum treatment of TB is 6 months. Uncomplicated drug sensitive tuberculosis treatment is 6 months, and this may go up to 2 to 3 years. Now, ladies and gentlemen, we would understand that it is very difficult to be compliant, to be consistent to anything on a daily basis for 2 to 3 years. Anything, forget taking drug treatment. Think about how many of us can say for sure that for past 3 years, for sure, daily, I took a bath. Now, this may sound a bit funny. What is the relation? But I'm just giving an analogous thing. Very difficult to be consistent on anything. And saying is one thing. Obviously, you can say that, oh, I did everything daily. I was very consistent and compliant. But actually doing it. So if you are not consistent and compliant, or if you are not confident that you were consistent and compliant with daily activities like taking a bath, imagine how difficult it would be to take treatment, to take medications for that long period. Apart from this, the expenditure it brings in, the the side effects it brings in, the psychological effects, much more important are the psychological effects rather than the actual side effects of the drugs. The social stigma it brings in, and the expenditure it leads to, leading to disturbing of the household budget, and in fact pushing some people actually into poverty. So when we say about NTEP basically the vision is to have 0% death, 0% disease, and most importantly 0% poverty due to tuberculosis in India. 0% deaths and 0% poverty are very, very important objectives due to tuberculosis. So this is what we are talking about. Why is patient support needed? Firstly, and this is something unique about tuberculosis. It is a unique disease. It is a special disease. It is one of the largest and the most significant public health problem, if not the most significant public health problem. It has been lingering around for not for decades, not for centuries, but for millennia, and we are trying to fight it out. And apart from all this, one of the most key things is that it affects the middle-aged breadwinners. So this way, it is not only a personal disease, it just does not affect a person, but it affects the whole family. It would affect the whole household, especially amongst households where there are only one or limited number of breadwinners. And that is why what becomes more important is to limit or preferably eliminate the OOP. OOP stands for out of pocket expenditure. Out of pocket expenditure. Now, this out of pocket expenditure and the breadwinners being not able to go to their routine, profession, be it a job, business setup, or whatever, either temporarily or permanently, both these together are reducing the financial status, the socio-economic status of families in which people are affected with tuberculosis and pushing many of them into poverty status, that is below poverty line. With that, the objective is to support patients' nutritional needs. And how do we aim to do that? How does the system aim to do that? By giving financial incentives, especially directed towards nutrition. Because it's a vicious cycle, undernutrition and tuberculosis. It's a vicious cycle. More the undernutrition, more chances of having TB. TB in itself pushes the body into an undernourishment status, and it's a vicious cycle. And apart from it, one of the good points you can say is that this program or this patient support system part component of this program aims at creating linkage to other social welfare schemes. Social welfare schemes can be for the elderly. Social welfare schemes can be for the tribal people. They can be for women. They can be for children. They can be for pregnant and lactating mothers. They can be national level, state level, or urban local body level. Ultimately, if a TB patient gets those schemes under the same head, be it a health related scheme or a nutritional scheme or a financial scheme, some kind of extra benefit transfer, it will ultimately help him and his family fight against this disease of tuberculosis. Continuing on that social aspect, the aim further is to address the social determinants of TB. And this we would all know that whenever we say the epidemiological triad, agent, host, and environment, so one of the most important disease where environmental factors and especially the social environmental factors play a big role is tuberculosis. And what are the chief social determinants? First, as I already mentioned, undernutrition. I've already talked about poverty. Again, a vicious cycle. Poverty leads to the disease. The disease in itself increases the expenditure, leads to temporary or permanent loss of jobs, and back to poverty. And very, very important is the social stigma. The person starts feeling left out. Now, a very brief of this was experienced by people who were affected by COVID-19, especially during the earlier weeks and months of pandemic. People used to not even treat them as humans. They used to treat them like aliens. But that was for days and weeks. Here we are talking about months and maybe even beyond. There is a stigma against tuberculosis patients even after they have completed treatment. So medically, we are labeling them as treatment completed, or medically we are labeling them as cured of TB. But the society remembers that this particular person had a TB someday. So they would say, don't come near our kids, don't come into our household, don't share meals with us. How are you coming to job? And all those things, which further lead to a worse situation for a person and a family where tuberculosis has hit. So under this patient support system, there is in the first heading, we have a direct benefit transfer. So firstly, we talked about nutrition, undernutrition, and nutrition related support. So for that, we have something known as the Nikshay Poshan Yojana. Now, the first column talks about the schemes. The second column talks about the beneficiaries. Very important to know who are the beneficiaries. And the third column talks about the amount that would be transferred. So this Nikshay Poshan Yojana is for all confirmed tuberculosis patients, be it DSTB or DRTB. Now, what is DSTB? So it is drug sensitive tuberculosis. And what is DRTB? It is drug-resistant tuberculosis, which would include MDR, XDR, IDR, monoresistance, multiple forms of resistance, and others. So beneficiaries for Diksha Poshan Yojana are drug sensitive as well as drug resistant tuberculosis patients. And most importantly, they can be even from private sector, and obviously it applies to the patients who are taking treatment from the public sector. And how much is the amount? The amount is rupees 500 per month, which is directly which is to be directly transferred into the bank account. So please remember this short form. This you would hear in various places in society. It's not only about health related programs, but there are various schemes of government, state or national or urban local body government. So various forms of government, various schemes where money is transferred directly into the bank account. That is known as direct benefit transfer, and the abbreviation is DBT. So moving ahead, there is a special support to patients who are from tribal, hilly, or difficult to reach areas. This was 500 per month. So as long as the patient is taking treatment, every month 500 rupees would be transferred. This special support for tribal, hilly, and difficult to reach areas is for all confirmed TB patients who reside in such areas, and this is a one-time transfer of rupees 750. So such areas, the concentration of Anganwadis, the concentration of sub-centers, concentration of PHCs, concentration of healthcare providers as a whole, Anganwadi workers, Asha workers, everything would be less. They shouldn't feel left out, and the program intends to reach to each and every citizen of the nation. So they shouldn't feel, marginalized in any form, and that is one of the reasons there is a special transfer of rupees 750, which is a one-time transfer. Now there is something known as a treatment supporter, and the treatment supporter is going to get an honorarium. Treatment supporters can be medics or paramedics or even general citizens in some cases. And for a completion is very important. This is not about enrollment. This is about when a person is completing the TB treatment. So for completion of TB treatment, if it was a drug sensitive TB, rupees 1000 would be given to supporter. And if it was a drug resistant TB, because the drug resistant TB would have a longer treatment course, it may be 9 months, 12 months, 2 years, or even beyond. For that, it would be 5000 rupees one time. Obviously, these both are one time transfers. These are not for patients, these are for treatment supporters. Even further, we have incentives for those who notify TB cases and incentives for those who notify outcomes of TB cases. Now, such people can again be medics, paramedics, or general citizens. If you notify a TB case of your locality, society, city, whatever, then as a for being an informant or for notifying, you get 500 rupees as incentive. Again, one time, obviously, one time 500 rupees transfer as a notifier of a TB disease. And if you facilitate outcome declaration, if you notify, inform outcome of a TB patient, then again, medics, paramedics, or general citizen would be given 500 rupees as incentive, which is again a one-time transfer. So for undernutrition or to prevent undernutrition, to have better nutrition for Poshan, we have the Nikshay Poshan Yojana for TB patients who are on drug sensitive or drug resistant TB, private or public sector, 500 rupees per month. If the patient is from tribal, hilly, or difficult to reach areas, 750 rupees one time transfer. Treatment supporter honorarium for completion of treatment. The treatment supporter gets 1000 if the patient was drug sensitive, and 5000 rupees one time if the patient was drug resistant. And for notification of treatment and notification of outcome declaration and notification of TB patient, anyone, virtually anyone, medic, paramedic, or general citizen, would be given a 500 rupees one-time transfer. And all these are direct benefit transfers, which would be directly credited into the beneficiary's bank account. Now, the ASHA workers or the community health volunteers have also been incentivized under two heads. Firstly, for TB patients, they have to have 100% bank account linkage And this linkage with bank account has to happen within 15 days from the 15 days, obviously, from the date of treatment initiation. So patient goes with symptoms to a healthcare provider, or incidentally, a TB is diagnosed, a TB is confirmed, a treatment is now started. Now, within a period of 15 days, the ASHA or the community health volunteer are supposed to have bank account linkage so that the patient can start having his direct benefit transfers of Nikshay Poshan Yojana, of any other special scheme like hilly tribal difficult areas, and as we saw 2 slides ago, because there is a linkage to other social welfare schemes also. So if there is any other social welfare scheme under which he or she is eligible, then such bank account transfers, such DBTs can also start. But this has to be facilitated within 15 days, and if ASHA or community health volunteer are able to do it, then they get an honorarium or an incentive of 50 rupees per patient. This is per patient, obviously it is one time. And similarly, we have something known as TPT. What is this TPT? TPT is TB prevention, TB prophylaxis therapy for household contacts. I'll make a separate video on that. So for successful completion of TPT, for household members of patients for whom these ASHA community health volunteers are treatment supporters. So for such successful completion of TPT, they get 250 rupees one time. Now, interesting it is for patients bank account linkage, it is 50 rupees. But for prophylaxis therapy completion, it is 5 times more, 250. Why? Because obviously TB treatment, completion of TB treatment is very, very essential. But similarly, wherever applicable, this TPT is also very, very, very important. Moving ahead to the novel initiatives under this NTEP. So there is something known as an informant module. So earlier, the informant module only used to cover the private practitioners, the GP or the registered medical practitioners. Now it covers everyone. So any citizen of India can be an informant and can claim the informant incentive of notifying TB case or notifying a treatment completion. That is the outcome declaration. Next, we have monitoring and support from the program side for the states and union territories. And for this particular step, there are various partners that have been enrolled. First is the WHO, that is the World Health Organization. Second is the union, which basically stands for International Union Against TB and Lung Diseases. Next is the CHAI, which stands for Catholic Health Association of India. And then further NTSU and STSU, that is the National Technical Support Units for Tuberculosis and State Technical Support Units for Tuberculosis. So just to repeat, monitoring and support for states and union territories. And for this particular step, apart from the program, apart from the health ministry, apart from the union government, apart from the state governments, obviously, there are other partners and stakeholders who pitch in: the World Health Organization, the union, that is the International Union Against TB and Lung Diseases, Catholic Health Association of India, and National Technical Support Units and State Technical Support Units for Tuberculosis. Next, very important step is implementation arrangement. Now you can talk about all the, we will transfer this, we will transfer that, this would be given, that would be given, etc., etc., etc. But if in reality, on the ground level, if it doesn't reach the end user, the end user may be a ASHA, the end user may be a patient, the end user may be a notifier, the end user may be a private practitioner, anyone, a general citizen, according to whatever heads we saw in the previous 2 slides, if it doesn't reach, then it leaves a very bad impression of the program. And often than not, such programs are bound to fail because we are declaring some kind of incentive. We are declaring some kind of, monetary remuneration for help from the ASHA workers, from the private practitioners, from general citizens as a whole, and also for the TB patients themselves. And then if we are going back on that, if that transfer doesn't happen, if they don't receive their incentive, what they are supposed to get as per the program, then it becomes, it gives a very bad impression on the program. And it's not the right way to go if we look from the social perspective of any program implementation. So that is the implementation support. And for that, for facilitating the right amount of money transfer within as minimum interval as possible, there is something known as the PFMS, which stands for Public Fund Management System. And all funds, as already told, would be DBT. That is, the bank account would be linked and there will be a direct benefit transfer into the bank account. Moving further, there is a national TB call center setup. This is the number 1800 11 6666 1800 which is the national TB call center, and we have called it under this program as a Nikshay Sampark. Nikshay, I believe we all know. Nikshay, Shay stands for tuberculosis. In Hindi or in Sanskrit, it is known as the Kshay Rog. And Nikshay means rooting out or eliminating the Kshay Rog, that is the tuberculosis. And Sampark obviously means to establish a communication channel. So TB elimination communication channel, the TB call center. Finally, what is the role? What are the roles and responsibilities of this Nikshay Sampark? So firstly, it is meant to resolve TB queries of patients or their family members which are taking treatment for tuberculosis. Any queries they have, it is supposed to resolve. There is an add-on integration with the NVHCP, which is the National Viral Hepatitis Control Program. National Viral Hepatitis Control Program. So there is an add-on integration into the same call center, the same communication channel, and thereby this call center has the role and responsibility of resolving hepatitis related queries. Again, they may be patient queries, or they may be family member queries or general citizen queries. Besides, there is telecounseling of TB patients regarding their disease, their treatment, what would be the duration of treatment, when should they contact the health center, what should be a routine follow-up, what should be an emergency follow-up, etc. A satisfaction survey is taken regarding the various steps which we have already talked about, be it the benefit transfer, be it the treatment, be it whether the drugs are provided, whether a follow-up was conducted from the health system side, when the patient visited the health center, whether there was adequate services provided, etc., etc. So a satisfaction survey for TB patients is done using the National TB Call Center known as the Nikshay Sampark. Then, if any TB patient or any stakeholder has a grievance to enroll, then such grievance management, enrollment of grievance, forwarding it to the adequate body, seeking a resolution, if possible, communicating back to the grievance reporter what was the outcome. All that is also done from the Nikshay Sampark Center. And finally, there is IVRS in regional languages along with Hindi and English. IVRS, that is the Interactive Voice Response System. IVRS is something which is very common. Any call center you call for any, the help center or customer care, which we call, there is an automated message being played, where they may be suggesting you to go to this step, you have to dial 1 or 3 or 5 or whatever. That particular thing is known as Interactive Voice Response System. Now, this is available in Hindi and English, but most importantly, we know in India, it is very important that if information has to be, passed on, or information has to be collected either ways in an efficient way, then you have to include regional languages. For a Marathi speaking person, for a Bengali speaking person, for a Tamil speaking person, if uh, your way of communication is only in Hindi and English, then obviously the communication either ways will not be very efficient or effective. Now, any community medicine student should always understand that whatever we read, we need to have a bit of a critical analysis or critical review of the same. Now, some call it advantages and disadvantages. Some may call it merits and demerits. Some may call it pros and cons. One of the technical way to go about is that you do a SWOT analysis: strength, weakness, opportunities, and threats. Strength, weakness, opportunities, and threats. Strength is what are the good points. So, for example, we are addressing the social stigma. For example, we are addressing the undernutrition thing. For example, by doing the direct benefit transfer, we are trying to address poverty. We are using direct benefit transfer, so we are not keeping any middleman, any office clerk, or any office point of contact. We are directly linking the bank account and transferring the money right into the bank account. Then we are giving special incentives for far-fetched area patients. We are incentivizing those who notify the a new case of TB. We are incentivizing those who notify outcome of TB. We are incentivizing treatment support for drug sensitive as well as drug resistant. And the drug resistant incentive is 5 times more. Few slides ago, we saw 5,000 rupees for drug treatment supporter of drug resistant TB and 1,000 rupees for drug sensitive TB. So all these are good points. Weaknesses. Now, weaknesses need not always be, bad points. Weaknesses would be something like, we are saying that tribal hilly or far-fetched areas we would reach. But at places, your health system, where your health system is not existent at all, you don't have a Anganwadi, you don't have a mini Anganwadi, you don't have a sub center, you don't have an Asha, you don't have an Anganwadi worker. And anyways, even the private sector reach over there is very less. How are you going to, gain confidence of patients of tuberculosis? Firstly, how are you going to catch hold of them? How are you going to diagnose them? How are you going to try, treat them? So maybe the program, or at least the patient support system, should talk more about this, should have more details on this. And these details need to be more of a guideline which can be customized at a local level, because something that would work in a riverine area may not work in a sandy area. Something that would work in a mountainous area may not work in a tribal district. Something that would work in Northeast may not work in Rajasthan. Something that would work in Himachal or Kashmir may not work in Tamil Nadu. So that way, that is one possible weakness that we can talk about. Then obviously the efficiency of all these services. We have said that we would run a call center, we would cater to all the queries, we would do counseling, we would take satisfaction surveys. Will they be actually taken or not? That is a concern that we need to look about. Then obviously, this is patient support system, but this the the support has to be secondary to the diagnosis and treatment. The support system cannot override the importance of diagnosis and treatment, because at the end of the day, we need to have a complete treatment for each and every TB patient if we were to achieve 0% death, 0% disease, and 0% poverty due to TB. So these are some potential weaknesses. Now, whatever is a weakness, if you are ready to improvise on that, then that is what becomes an opportunity. Opportunity. So I'll draw a upward facing arrow. That is the how whatever is provided can be further improved. So first we said that local guidelines may be specified. So local guidelines can be improved, can be included. It's an opportunity for the program. We have given a basic structure which is to be implemented pan-India, but maybe for a sandy area, there can be some extra local guidelines. For a hilly area, there can be some extra local guidelines. So for a hilly area, we might have seen something that works in the hilly areas of Uttarakhand that can be, you know, uh, that can be communicated to other states and areas also. So that may work in hilly areas of Maharashtra also, or hilly areas of Tamil Nadu also. Now here we are talking about link with hepatitis control program. Similarly, there can be linkages to other program also. which is an opportunity. So other programs would include AIDS control program. Other programs would include leprosy elimination program. Other programs may include vector control program. So not necessarily infectious disease programs only, but yeah, other programs can be linked. So these are possible opportunities. Also, the amount that is being transferred that needs to be revised at a regular interval. See, if you are giving say 500 rupees per month to a TB patient in 2023, and if you are giving same 500 rupees to TB patients in 2028, then the credibility is some way lost. Then you are not addressing the problem that 500 rupees the value in 2023 and the value in 2028 would be totally different. Similarly, maybe patients who are from urban areas, metropolitan areas, maybe an extra incentive may be given because 500 rupees in a rural area versus 500 rupees in a tier 4 area, tier 3 area versus tier 2 area versus tier 1 area versus metropolitan city is different. We understand, the importance or the value or the worth of 500 rupees changes according to the city, town, or village you are located in. So these are few opportunities. Now going to the threat section. So threats basically, if I have to put it in one word, is basically if you become too complacent or too overconfident on your strengths, then that is what could become the threats of your program. So one threat, for example, I already said, one threat is that the patient support in itself, the direct benefit, the notification of outcome, the notification of patient, this should, or the importance of all this should not override the importance of diagnosis and treatment. The diagnosis and treatment is like the core of the program. That the importance of that cannot be undermined. That treatment, be it category 1 or category 2 or a MDR treatment or a XDR treatment or other forms of improvised treatment, that basically would kill the tuberculosis, would protect the lung of the patient or any other organ affected, and would lead to the recovery, would lead to the treatment completion and actual cure if possible. So that is one of the threat. Second threat, obviously, wherever there is money involved, there are all forms of, all forms of notorious activities may get involved. Uh, Amounts like 5,000 rupees are not small amounts. So, false notifications, fabrication of data, all that becomes a threat. So there has to be, we talked about monitoring, so there has to be strict monitoring and maybe an independent monitoring, a parallel monitoring from agencies like WHO once in a while can be done. There have to be evaluation of programs, actually how many patients were enrolled, how many patients were that in that locality. So basically, in other words, I mean to say is suppose a district has 100 TB patients registered and money is being transferred. So your money transfer as compared to 100 TB patients should not be for 80 or 75 patients, obviously. It should be as close to as 100 and preferably to all 100. But at the same time, if a district has 100 TB patients, there should not be 110 TB patients registered for direct benefit transfer. So you can add to these strength, weaknesses, opportunities, and threat. This is known as the SWOT analysis, SWOT. Now you can write it in a paragraph form, 4 paragraphs, 4 sub-paragraphs, point wise, but generally it is done by drawing such 4 quadrants. And this can be and should be done for any and every topic